Welcome to GW Integrative Medicine, the podcast about disease prevention and health promotion from the Office of Integrative Medicine and Health at the George Washington University School of Medicine and Health Sciences.
I'm Dr. Misha Kogan, an associate professor of medicine here at GW, medical director of the GW Center for Integrative Medicine, and founder and executive director of the Access to Integrative Medicine, or as we know it, AIM Health Institute.
And I'm Janet Rodriguez, the office's administrative director. Today, we're talking to Jeffrey Geller, who's a nationally recognized expert on group medical visits. He's a family physician, chief medical officer of Kronos Health in Lawrence, Massachusetts, and president of a nonprofit called the Integrative Center for Group Medical Visits.
Jeffrey is particularly well known for his work in creating the largest group visits program in the United States and his ideas about empowerment. He's on faculty of the University of Massachusetts School of Medicine and Tufts University School of Medicine.
Welcome to the podcast, Jeff.
Thanks for having me. I'm really excited to talk with you guys today.
So, Jeff, let's start with something super basic because I don't know if all of our listeners fully grasping what is the group visits and sort of what is a little bit of a historic perspective here on the groups in U.S.
Yeah, so, group visits, people getting together in groups, obviously, that's happened forever, right? And there's a lot of support and nurturing from being with a group of people who might be like-minded or have a common goal. So a lot of people think of a group and they think of a group of people. And what I think we're going to be focusing on today are what we call group medical visits. There are many different terms. You'll hear shared medical appointments, shared medical visits, medical group visits. I like to just call them group visits. But group visits in the medical context are where you see people together collectively as opposed to seeing them one at a time. It's a way of delivering healthcare, a way of sharing resources, having more time with your patients. And so when I do a group visit, I usually pick either an activity that a group of people might have in common. So we might have a group visit with acupuncture, and that might attract people who have chronic pain. I might have a chronic pain group for support where people talk to one another about chronic pain. We have addiction groups, so people who might use Suboxone, and they will come every week or every month or whatever the nature of it. To me, though, what makes a group visit different than just a group of people getting together is the beauty of reducing loneliness, creating interconnection between people, building relationships. Often, what people struggle with most in health, are the social determinants of health, which need to be overcome, or just the motivation to make lifestyle and health changes. So that's a big answer to a big question.
And Jeff, you've been doing the groups for over 20 years. How did it all start? And give us a little bit of a historic background on particularly your early program and then currently what you're doing.
Sure. Yeah, absolutely. I don't know where I got this thinking from, but I was very interested in loneliness coming out of medical school, and that would have been in 1990, 1992, when I entered medical school, and did a little bit of research. And believe it or not, there wasn't a lot of research on the concept of loneliness as a health condition. Mainly countries in Europe were leading the way. I remember Norway and Sweden had done some research, and they showed that loneliness is bad for your health. People who were lonely were 5 times more likely to die of all causes, as I recall. And so I just really connected with that. And I went to residency, in Lawrence, Massachusetts, which is one of the poorest cities in New England, continues to be one of the poorest cities in New England. And started to tackle the problem, how can we reduce loneliness? I did research, and the research showed that people who were lonely were using the emergency room almost 3 times more often than people who weren't lonely. People who were lonely were using our health clinic 6 times more often than people who weren't lonely. So I got to admit, I was a bit of an introverted person, not who will represent today. You'll hear me being very confident today, most likely, because this is what I know best. But it led to bringing people together in groups. How do you reduce loneliness? Well, we identified it was a problem. We did research. And because of the research, we were able to get a grant. And so, honestly, I didn't know what I was doing when I started. I'll be brave enough to admit that. But that was like 1996, where I said, well, let's see if we can reduce loneliness by bringing people together. I received a very large grant by the NIH and was able to do research on diabetes and diabetes groups. And cutting ahead 2 or 3 years of developing those groups, I found that the research showed that not only did not only did the loneliness improve, but diabetes improved. There was weight loss, blood pressure improved. And so it became very clear to me that bringing people together in a group had these other effects, which were very, very favorable on health. And that allowed me to establish what people use nowadays as the standard billing models in the U.S. for how you do group visits. So it became a very sustainable model, and one that was that I've done for now 28 years, 27. So, really things I've learned along the way that make for successful group programs were ask your community what it needs. So the very first group I did was a Tai Chi based group. And most of the patients I take care of are from the Dominican Republic. And I'll just say they didn't seem to prefer Tai Chi. And we ended up doing something very similar to what people would call Zumba nowadays. We did dancing. We had food together. We did things that were very culturally appropriate. And our groups grew and grew. And, we started with diabetes groups and weight loss type groups that were popular. And then we moved into chronic pain groups, all back in the late 90s. I continued to do research on loneliness and it just became clear to me this is how I wanted to practice. And then slowly we added every type of group you could ever think of. We had prenatal groups, which were outside the centering model. We've had groups for insomnia, groups for children, groups for anxiety, smoking cessation groups, groups for asthma. And most of them are very similar. Just bring people together, have them share what they know, give them support, find out how in our community we can best tackle these problems. And it slowly led to a very large program. And that was in a community health center setting. About 3 years ago, I moved to a private practice setting, which I call private practice for the underserved, because it's still in Lawrence. It's right down the street in an old Taekwondo studio. And we were able to start right up because my goal is to really have a completely group medical visit practice, which we were achieving pretty well. And then COVID has kind of thrown us for a little loop.
Jeff, can you tell us a little bit about how COVID has affected or impact loneliness?
Yeah, I can definitely speak to that. And I can speak to how it affects our
Because
programs.
I'm quite sure that's something you've been seeing with your patients and your programs.
Yeah, the city I live in, COVID is just one in a series of real tragic events that have occurred over the last 5-6 years. And so the idea of trauma, being traumatized, people being displaced, living, being virtually homeless, living on a couch. How am I going to finish school? How am I going to, reach my goals? That's not new because of COVID in my community. We have a lot of people from Puerto Rico, and the hurricanes devastated their families. Lawrence had gas explosions about a year before COVID happened, where 1/3 of the people in our community lost their housing. Not sure if you guys heard about that. It was a national news story. So, our groups really are designed at bringing people together and reducing loneliness. Of course, the group will be called a diabetes group, or the group will be called a chronic pain group. But we've been working on mental health issues pretty much from the beginning. The groups were started as a treatment for loneliness. There's a couple ironies. So social isolation is increased, right? You have to wear a mask. You can't visit family members. Traveling isn't allowed. We have a lot of people who are, from other countries, and their families, don't live in immediately. And so there's a lot of social isolation, which in itself is not good. And loneliness is specifically the feeling that there's no one there for you if you really need them. And that can mean emotionally or physically or other. And so, certainly as you think of the pandemic, you don't have those resources as much. But the irony is we've all been through a common experience. So on another level, when we all have, we've started opening up our groups recently, everyone is just so lovely and so excited to see one another. And the level of connection is so much higher after going through the pandemic. In my practice, I lost about 45 patients, right? And everyone, and I can name most of them. And so we feel like the survivors are kind of recollecting, and everyone knows someone in our community who's been severely affected by it. So, we were very lucky because we already started a transition to virtual medicine before the pandemic. So the nonprofit, the Integrated Center for Group Medical Visits, was established so I could do some next level work beyond what I was able to do at the health center. And one part of that was I wanted to deliver virtual care to children. So in Lawrence, there are a lot of single parent homes. People are working third shifts, and the kids didn't have a lot of things they could do. So we had this program called POEM at Home, the Pediatric Obesity Empowerment Model, and it was going to be at home. So when the pandemic hit, I was able to switch most of my groups to virtual. And there's, so we were very lucky in that sense. We didn't just keep chugging along though, because there's real serious issues with technology access for people who are poor or underserved.
Yeah.
So, we never closed.
From hardware to having Wi-Fi.
Right.
Or being able to afford it,
Yeah, we did a lot though. We were able to negotiate for our patients a $10 a month. Comcast, I'll name them because they were generous. Comcast gave them cheaper internet. I was able to send my employees into their houses, which is something I couldn't do at the health center. But in private practice for the underserved, we could do it, whatever we needed to do. So, Marisol, I'll shout out to her, and Crystal, they've been working with me doing groups for 15 years at least. I'd say, hey, can you go there and help them set up their internet? And, even with COVID, we just took the best precautions we could, and you do the risk benefit assessment of things. And then we've received some grants over the years. And if you visit our website, you'll see who our donors have been. And so we're able to give technology to some people who really lacked it. But
what else is available on your website, on the nonprofit website?
So the nonprofit, it's a true nonprofit. I'm the president. I don't take a salary from the work. It's really about promoting group visits. And so if you're starting a group visit program, you often wonder, what are the consent forms I need? What are the legal ramifications? How do I bill? And so we have all those consent forms and all those documents that someone would need to start a group visit program in a downloadable, put in your title way. We have had a conference, and so that material is available. It can be free if you can't afford it, but we ask for donations to share some of this information. We have documents on how to do billing. We have information about what's going on in the group visit community. And as I mentioned, we have another conference coming up this year, so people can learn more about these things. We've never turned people away from our trainings or conferences because they couldn't afford it.
When is the conference?
This coming conference is going to be in September, I think September 16th and 17th. It's going to be a 2-day conference. The first day will be really the people who are doing group visits and pushing the envelope, sharing best practices, talking about higher level group visit things, but it's accessible to anyone. And then the second day is going to be more of a skill building. What do you need to go virtual? What do you need to, do those things? We're still collecting submissions for presentations. Misha, maybe you want to talk about cannabis in a group? I'm not sure. If I could
Hint,
draw you,
hint.
that would be great with your amazing knowledge base. But, so those are some of the things that are going on. And, I'd say the most important thing we did during COVID is we stayed open, because there were just so many people who needed to be seen, even though they were sick. And we
Mm-hmm.
took the best precautions we could. And if you didn't have technology, you didn't have a phone, you didn't have the language ability, you knew there was a place you could go, and, we would do our best to take care of you.
So, Jeff, I think the future of groups is very bright. It almost looks like every large institution is now beginning to adopt it. I've heard a couple of years ago a presentation from Cleveland Clinic, and it looks like they're doing something like 30,000 patient visits a year in groups. So, you've kind of always been a forefront and kind of the father of the field. Where do you think we're going? I mean, what's going to be the next big thing in groups?
So I think I'm part of the future. So our private practice for the underserved has moved into the capitated space. And we're one of the few practices, we might be the smallest practice, actually, that is doing direct contracting. And what direct contracting means is that you're not paid for the individual visit. So most doctors or doctor offices are paid. Someone gets sick, they go, they see you, you bill them, you get paid. Someone has pain, you treat the pain, you get paid. In our model, we're paid for keeping people well. And so we're given a lump fee to take care of a patient at the end of the year. I wish it was the start of the year, but we're given a lump fee to take care of a patient. And then the better we do at keeping them healthy, the more likely the higher our revenue will be. And I believe this is the model we'll be moving towards, because it's really basically paying the medical system to keep people well. And what we know about group visits, as you heard me alluding to, some of my earliest research from 25 years ago showed that people who are lonely tend to be high medical utilizers. And so if you can reduce loneliness, create more open access. So my patients, they really know me. They can pop into a group visit any day. So higher access, and then higher number of services. Because we take care of a larger number of patients and have a higher efficiency, we currently offer massage, chiropractic, acupuncture, functional medicine, nutrition, exercise, yoga, chronic pain support. These are things that sound like they would cost more, but actually we're doing this in lieu of the traditional medical care, and it creates more access for people and reduces costs. So I think the main motivator of group visits right now is higher touch and lower cost. Now, the future of group visits, where I get a little concerned is, so ICGMV, we're a national organization. And as a national organization, we know that there are 50 different models of group medical visits, right? So each group tries to sometimes license their own model and say, my model's the best. And truly what's behind group visit success is often something I refer to as the group inclusion effect. So simply by feeling like you're part of a group, your health improves. They've shown your stress reduces, you're less lonely. And in and of itself, that improves your health overall. And so the real goal of all groups should be to interconnect the participants, not necessarily to teach a curriculum. And so I think the future is going to be, so all of these organizations have started their own group visits, just like I did. And I initially was like, okay, we're going to deliver information. My first group visits were, this is what a hemoglobin A1C is. But it turns out our patients, education is needed sometimes. But really what our patients need, especially in my community, is support, is creative ideas to get through the barriers. I can't just say eat pomegranates because they're healthy. My patients would be, where's a pomegranate? I can't afford a pomegranate. How do you eat a pomegranate once they look at it, right? So we have to do a different type of medicine, which is, well, what is in the community? How can we change the community?
You have to eat pomegranate altogether.
Is that it? You eat the skin too? I always use that as an example.
I think you're bringing in a critical point. I mean, the medicine is usually practiced as something like, there's a standard and everybody follows this. And here, it's pretty clear that the process has to be very community oriented, and community should really dictate, at least in some part, what's going on in the group. And you've really championed this whole concept of participatory engagement by the leaders. And I think in the beginning, in some of the early work you were doing, you guys had you would train some of the community leaders to basically become co-leaders of the group, right?
Yeah, absolutely. And when I moved from my last practice to the new practice, I was on the radio, and people were calling in on the radio. People that I knew. When are our groups going to start again? And we have everyone is just multi-purposely trained in a group. So we have an exercise instructor who's someone from the community that we've trained, and we pay them to lead the exercise. But if they're not there, my medical assistant, she can lead the exercise, or one of the participants in the group can lead the exercise. Our group, some of them have been in existence for 20 years, right? So yeah, I think the facilitation of a group. So when we do trainings, we either do a didactic type of training or a more interactive how to become a facilitator type training. And when we do those trainings, some people prefer the didactic and some people prefer the facilitation part. But I know that the facilitation, how you lead a group, is much more important than what the curriculum is. If you make people feel invested, connected, important, they're going to keep coming, and even if you're doing a bad job at teaching, they'll make you a good teacher.
Mm-hmm. So you mentioned cost, which I think is critical aspect. Medicine doesn't change until money is clarified, so to speak. So what do you think the next research strategies? Because I think we have to demonstrate the cost savings, and how are you thinking about it, and what are your particular research ideas that you're thinking forward?
Yeah, so we actually are a test practice. As I mentioned, we're working in an underserved community. We're collecting low reimbursement from Medicare and Medicaid. And so we've negotiated a capitated care agreement. What that means is we're going to know exactly how much we receive and exactly how much we spend. And we will be able to compare that to any other community health center or any other private practice across the country. Right? And we are keeping very accurate data. And so if we succeed, which is looking pretty likely, then we will be able to share what we've learned. I imagine it will be a very big deal, Misha. So, to me, I have opportunities to be a leader of an organization, but I am the Integrated Center for Group Medical Visits, but I continue to be a clinician. And I think it's through leading groups and showing that these models work. The proof is in the pudding, so to speak, that will be the next level. And so I'm confident we're going to have cost savings because of the group visits we provide and the services we provide. Our patients aren't getting back surgery. They are doing yoga. Our patients aren't going to the emergency room because they'd rather come and see me in the group and talk about their problems. And these things save money. And now we're in a position to be collecting when that happens. So I think that's the next step. I know Centering Pregnancy has put out some white papers about doing capitated billing systems as well, where they're looking for models similar to what happens when you're pregnant. So currently a pregnant woman, during her pregnancy, there's a lump sum that's paid to whoever does the delivery at the end of the pregnancy, that pays for all the services that go into it. And that's worked for years. I believe the VA system is doing some real innovative things too, because they are a cost-contained organization. I know the Samueli Foundation and Institute and Wayne Jonas were doing a lot of work there as well.
Jeff, what advice would you give providers who want to start doing group visits?
Okay, well, that's a very big question. When I go out to sites and train different sites and group visits, sometimes I go for 4 days. We talk for 8 hours a day about how you're going to start your group visits. But it doesn't have to be complicated at all. If you are a practitioner, you need to think about what is your best material. What are the things you're telling every patient every day? Is it how to eat? Is it how to exercise? Is it, what are the things that you could say that are the most efficient things? And then go through your own practice list and find 6 to 10 people who might be lonely, who you think might benefit from support. It shouldn't be a choice of who has the worst managed diabetes, because you don't want people all with bad managed diabetes coming together in a group. It should be a group of people who have diabetes, right? So that some of the people who are struggling can learn from some of the people who are succeeding. And, so pick what is your patient made of? For me, it was to treat loneliness. And so as you're leading your group and you have patients who are more lonely, know that they're probably also the people who are coming to your office more often. And so, you can kind of choose some people and put them in the group and ask the group, what do you think we should do? So that's the simplest way, and create a safe space. I guess I'd recommend get training. We offer training, and it can be free if you need it for free or whatever you can afford at ICGMV. Unfortunately, we just finished a cycle of training, though. In the end of April, I think we have a 2-session facilitator training. But you can check our website, www.icgmv.org, to find when our next trainings are. But, some people are intuitive. You may not need to be trained to facilitate people. But, start with your own patients. Start small. When you start small, you're not able to afford things. What my secret to success has been is being big. When you're bigger, I have a schedule. It looks like camp. A patient comes to my office and they go, I have pain. And I go, oh, that's terrible. Are you working? Are you not working? Oh, you're not working. Okay, well, let me show you. You can do yoga, you could do Tai Chi, you could just meet with other people. Do you want to do a cooking group? What do you think you need for your pain? Right. And okay, are you on narcotics? Fine. Am I your prescriber? So once a month, I want you to come to one of these groups. And, I want to see if we can make your life better. And not just, here's the medicine. Why don't you see the orthopedic and get an injection? It's you are an active part of your own care. What do you want to do? Where do you want to go? And so by being large, it also allows us to have staff, right? You couldn't have a devoted group coordinator person if there's just one group a week, But in our practice at the health center where I used to work, I saw on average 5 patients an hour, if not more, doing group visits. And the average clinician was seeing 2.3 patients an hour. And that's at a federally qualified health center where, there are barriers to seeing people. And so by using that economy of scale, I was able to say, hey, look, let's use some of that extra revenue to pay for an exercise instructor, pay for a group coordinator, so it really amounted to quite a bit. And now that I'm in private practice, we're seeing the same thing. I'm seeing about twice as many patients as the other providers in our group.
Misha, I don't know about you, but this is so inspiring to hear this.
Well, so Janet, I know all this already, so it's not that. my main thing I got out of this is the fact that I think once we actually show how the capitated model compares to the standard, that's probably going to be a mudslide, because that's what everybody's after nowadays. So if that insurance will go after this, once insurance go after this, then that's it. I mean, then it wouldn't matter what academic centers are doing, because I actually think that they've been much slower at adapting this than they should be. I think there's just a lot of entrepreneurship that's happening, and a lot of small practices adapting it, and some academic centers, but not as much as I would like to see.
Yeah, there's a lot of hesitation. Over the years, I've often been challenged. Someone will say, "Is it fraudulent? Is there HIPAA violation? Is there, and they'll point out all of these things." And, I say, well, look, I'm not earning any more money than anyone else. Actually, I've earned less in my current job. Patients seem to be getting better care. There are no complaints. We're giving free services to people, and the insurance company doesn't have to pay extra. They're not paying extra for us to give someone a massage. We do that because we think it's the right type of care. And so over these 28 years, it's always been just so clear to me, like, this is the way we're going, almost like electric cars. There's a resistance to it because, but how are you going to fuel them? What about batteries? Isn't it wasteful, right?
Right.
But it turns out, no, that's not true. It's actually more efficient. And it's so, I think that, we're going to need another 2 or 3 years of data. Mm-hmm. We find out our first glimpse this July, right? So we started last April in this capitated model contract with direct contracting. And in April, they tell us, kind of how we're doing. And then in July, they actually pay us. So one of the things that has been a struggle, and it's just been a personal sacrifice for me and all the other clinicians that work with us, who are really great people who want to do amazing things for the community and change medicine, right? So that's the position we're coming from. And we're in a fortunate position where, we couldn't have taken this leap if I was in, extreme debt, and things like that. So we've had to go this whole year not collecting any money on our Medicare, Medicaid patients because we have to figure out what the capitated fee will be at the end of the year. And so a lot of practices can't do that. And so for that reason, small practices like us generally don't. We've tightened our belts. We're getting through it. We're almost through it. But it still seems like it's going to favor these larger organizations and larger companies. And they have their own, constructs, of what motivates them. So
yeah, we know AIM is trying to sort of line up itself with when your data comes out. So I'll probably be reaching out to you regularly to figure out. We've been trying to get kind of similar contract with one of the largest DC Medicaid contractors, and it's tough because a lot of this administrators and non-medical personnel they don't really grasp this, and it's a little bit of a work upstream to convince people that there's value in this.
Yeah, we've had some success though. Blue Cross Blue Shield of North Carolina recently put out what they think is the correct way to bill for group visits. And so that allows us to say, okay, this is the direction that insurance is taking. Insurance companies, I can't speak for all of them. I don't want to use a broad brush,
right?
But my sense is they want people to get good care, and they want it to be efficient and inexpensive. And part of that includes integrative medicine, and everyone has their own limit of what they think is good integrative medicine, what isn't, where's evidence end. But I think most people would agree that building relationships, reducing loneliness, giving people their own empowerment, ability to choose their own treatment, these are things that are going to have positive, return on investment.
Well, I think that's a great place to end, and I think that's all time we have for today. Jeff, thanks so much for joining. I think we'll have to have you back when some more data comes out. Janet, what do you think?
Absolutely.
I'd be happy to spend more time with you guys. And thanks for the work you're doing, pushing forward treatments for chronic pain and anxiety that are more natural, and for what you guys are doing in general with this podcast, getting more information out there about integrative medicine.
Thank you.
This is the GW Integrative Medicine podcast from the GW Office of Integrative Medicine and Health.
I'm Dr. Misha Kogan.
And I'm Janet Rodriguez. Thanks for listening.